Okay, so today we are talking about obstetric and gynecological emergencies, which you all know has anything and everything to do with women's reproductive health, pregnancy, all of those sorts of things. We're going to be specifically talking about anatomy and physiology, everything that's going on down there, the vocabulary for it all. We're also going to make sure that you know what to expect if you have to deliver or help deliver a baby. The steps, how it happens, what's happening inside the mother's body, what you have to do on the outside. We're going to talk about equipment. We've got some of these to mess with. We're going to talk about some things that can go wrong, different possibilities in terms of the birth or related to the birth that might become emergencies that you have to deal with alongside of just the actual giving birth process. So if you guys have questions, we can talk about as we go along, and I'm also going to have questions for y'all at the end. Okay, so anatomy and physiology, which basically y'all know structures and functions, first things we're going to be discussing. When a woman is pregnant, okay, y'all can sort of read this hopefully, it's large enough. Some of the things that you want to be aware of, some parts of the body that you want to pay attention to. All women have a uterus, except for those that have potentially had a hysterectomy, which is removal of the uterus. All women have one. Normally it's pretty small. It sits down like right in very low belly, that area, pubic bone kind of area. Small, you can potentially feel it as kind of a hard, like grapefruit-sized mass down there, sometimes smaller. But as a woman has a baby, the baby is, or the fetus is inside the uterus, and obviously the uterus has to expand to fit the fetus. The uterus is a muscle, so it can contract and expand just like any other muscle in the body. It's also why women who've had multiple births will occasionally, the births will change over time. They'll often be easier as it goes along because it's all these muscles working that are just kind of more used to that. They get more stretched out and the pregnancy becomes a little bit easier versus very first pregnancy. Other parts of anatomy that you need to be aware of, at the very bottom of the uterus is the cervix. Below the cervix is the vaginal canal. The bladder sits in front, the rectum sits behind. So y'all should remember this even from like health classes or whatever y'all have to take in 5th grade to go over like puberty body changes. The anatomy of a woman's reproductive system down there. Be aware also that inside the uterus along with the baby is the placenta, which is a sac. It's got full of blood, nutrients, blood vessels, a lot of things that helps actually connect the mother's nutrients in her blood and helps pass them along to the baby. So it's kind of the in-between that helps actually keep the baby going. There's a lot of blood in it, but it does come out with the baby. It's attached to the baby via the umbilical cord, which has blood vessels, nerves, again, in it as well, all connecting everything else. Who in here has ever seen a birth, or has anyone in here actually seen a birth, like mother, sister, aunt, anybody actually give birth? No? Okay. I was like 10 when my mom had my sister, so I actually got to see that one, but not everyone has. And I mean, well, we'll see pictures later, but you'll see what it all looks like in real time, or in real pictures. Something that you need to be aware of for women, because of all of these things here, the baby growing inside the abdominal area, obviously what used to be here in this abdominal area, all those organs are now being pushed out, right? So first the uterus is nice and small. As the baby grows, it starts to expand upwards, and all the organs that were in that space originally keep getting pushed up and out as well. So obviously the mother gets much, much larger, and there's all this extra weight. It's putting weight on the ligaments, so you might see the posture change. It's putting a lot of like stretch on ligaments and other things, so they're going to have some pain. It's also putting pressure on the aorta that runs down everyone's back towards the spine, right? Because you've got this big, heavy baby in there. Everything together weighs between 20 and 24 pounds typically. That can kind of vary based on the size of the infant and how far along in the pregnancy they are. So if they're laying on their back, if they're supine, all of that stuff is compressing the blood vessels that run up and down the back. And overall, with that compression, the blood's not flowing properly. It can lead to what we call supine hypotensive syndrome. Blocking that inferior vena cava, it's stopping blood from moving back up to the heart and lungs how it's supposed to. can cause dizziness, a drop in blood pressure. It's something you want to be really careful of. If you're dealing with any patients who are pregnant, even if they're not about to give birth, you want to be aware that because of the infant that's in their abdomen, that they're going to have this extra potential problem of hypotension in this particular case. So if you're transporting them, you don't want to transport them on their back. Or if you are transporting them on your back, you want to be very, very careful of this sort of thing happening. It can be a real concern. Okay, so if we're going to talk about pregnancy, I sort of mentioned that baby is developing inside the uterus. When it comes time for the mother to actually give birth, we're going to talk about that process, labor and then delivery of the baby. Okay, so labor and delivery is divided into 3 stages, first, second, and third stage. The first stage starts with the beginning of dilation of the cervix. So y'all remember from that slide, the cervix is at the bottom of the uterus. It begins to dilate, which means what? Okay, it expands. So it originally starts out very, very small. It's kind of like a puckered up mouth is essentially more or less what it starts out like in a pregnant woman, and eventually will just begin to open up. Y'all know, does anybody know in here what maximum or complete dilation of the cervix is typically considered to be? 10 centimeters, yeah. So the process of the first stage of labor begins when that dilation starts, and it ends when full dilation has been completed, so that 10 centimeter dilation. By the time the first stage is over, you're also potentially, or you're likely going to be seeing crowning. Crowning is when whatever body part is presenting is actually presenting at the opening of the vagina. So usually, hopefully, it's going to be the head. It's called a cephalic delivery, but it can also be potentially other positions that we'll talk about later. The second stage is the actual delivery of the baby. So if you're an EMT and you're on an ambulance and you've got a pregnant woman in your ambulance who thinks she might actually be going into labor. If she's in the first stage, if she's not fully dilated, if her contractions are real far apart, you can transport her, that's okay. We are going to talk about what it looks like when it's imminent delivery, when you expect an immediate delivery. But that's the second stage. That's the point at which you'd want to say, okay, we're not going to transport her anymore. We're going to go ahead and try to deliver this baby right here and now. I mentioned contractions. Y'all know what those are? Yes? Okay. Basically, the muscles of the uterus and surrounding are beginning to feel like they want to force the baby out. They're contracting as part of the whole opening up process and moving the baby down into the birth canal. So like the picture from, do I need to go back to it, with the uterus up here and then the vaginal canal down here, eventually everything is opening up and pushing down so the baby's getting ready to be born. Those contractions are what's making that movement happen. So in second stage, the baby is crowning, is ready to be born, and second stage is over when the baby is actually all the way out. Third stage is the birth of the placenta. So we talked about the placenta, we talked about how it's attached via the umbilical cord. The placenta is usually born, I say born, I mean that's essentially the same thing happens. The mother will give birth to the baby, and then usually 10 to 30 minutes later, she'll have another set of contractions and another process, and the placenta will be born as well. And you can see it there. That's what one looks like with the umbilical cord attached to it. There's going to be blood. It's going to kind of be that weird color because there's a lot of blood inside of it as well. It is typically attached to the uterus itself. Well, it is attached to the uterus itself during pregnancy, and then it detaches and is able to be delivered in the third stage of labor and delivery. Okay, so if you have a patient who is pregnant, we kind of talked about some of the body changes that are taking place with a pregnant woman. Here's a few more, and we're going to talk about what they look like inside versus outside. So a woman who is pregnant is going to have increased blood volume. Why would that be? Just take a guess. Okay, there's a baby in there, so more blood is necessary. There's more stuff going on. The baby has its own blood supply. They're not connected. They don't flow from one to the other, but more blood is necessary for the whole process. Yeah. because of that increased blood volume, you're going to see a pink coloration to the skin, perhaps more so than if you would. You've ever heard women or people who are pregnant talk about like the pregnancy glow? Okay, some of that is what that is, like the fact that they look all like, part of it's that they're super happy usually that they're having a kid, but some of it is actually just the natural effect of having more blood in you. You look more pink and like glowy. Other things that are going on because of that increased blood volume, what do you think is happening to the blood pressure? It increases as well, yes. Okay, you're going to expect to see increased blood pressure. You're going to expect to see an increased heart rate. You're going to expect to see an increased demand for oxygen. At the same time, what is happening to the lungs as this baby is being growing larger and larger and it's all pushing up and around and out? What's happening to the lungs? Well, the baby's lungs are, but the mother's lungs, do you think they have as much room to expand? No. Everything overall, especially, I don't know if you've ever known anybody like up close and personal who's been in those final stages of pregnancy, but they complain about always being in pain, never being able to catch their breath, because the baby's filling up a lot of room that used to belong to other organs. And so those organs, the liver and everything else, are being pushed upwards, putting pressure on the diaphragm. That diaphragm, all that pressure upwards is making it hard for it to ever expand out properly so you can breathe properly. So they're going to have decreased lung capacity. At the same time, they're also needing more oxygen. So it's making it even harder on their bodies. Obviously, the fetus is growing. The uterus is enlarging. From the outside, you're going to see the big belly. This presents different on different women. Some people, it kind of depending on muscle tone and everything before pregnancy, it can look, you know, mostly flat for a long period of time, and they suddenly seem to like pop and just get really large. They can kind of have a gradual growth. It varies based on the person, but overall, obviously, this has to happen for there to be room for a baby. I was mentioning the ligaments are going to get stretched. The ligaments of your back and everything, bones surrounding this whole area, your pelvis. You're carrying the extra weight of the fetus, so it's just overall putting a whole lot more pressure on the woman's body. And it's going to lead to things like pain or perhaps a change in posture. When you are dealing with a patient who is pregnant, especially one who believes that they are entering labor, you want to still assess them like any other patient. You still want to do the types of things that you would normally do: name, age, your sample history, OB/QRST. You want to still ask those questions. Obviously, there's a good chance that has to do with their pregnancy if they're experiencing contractions and things like that. But they're still a patient, and you still want to keep your mind open for just anything else that's going on. You want to have this information. If you are so set on delivering this baby that you forget to ask some really important stuff, you may not know that your patient is allergic to a certain medication, or even some other things that might be necessary to properly treat them. So you want to focus on that delivery, but you still want to do the proper assessment in terms of knowing enough information about them to pass that on to hospital staff. Other questions you do want to ask the woman who's in labor. You want to ask if it's their first pregnancy. I did mention that women who it's their first pregnancy, their body isn't as used to it. A woman who is in her first pregnancy, labor on average takes between 16 and 17 hours. So that is from the first start of that first stage all the way through to the end. And it can take longer. I mean, I've heard horror stories of much, much longer than that. On the other side, women who've had multiple pregnancies, 3 or 4, their bodies are used to it. Their muscles, aren't as super intense in terms of not being able to do the proper contractions and everything. And so the actual labor portion can be much, much shorter. When my mother had, I'm one of 6, but when she was having her 4th kid, I think I know we waited as long as we could before going to the hospital, but we got to the hospital at 8 a.m. and my sister was born at 8:13. It was very quick once it started. It was probably about 4 hours total of labor for her because it was her 4th kid, and it was just like her body just did its own thing. So you want to ask how many pregnancies they've had. You want to ask how many children they've had. Sometimes a person might have been pregnant but not given birth due to miscarriage or something else. So that's another question that you want to find out the answer to. Just have a better picture overall of your patient. You'd want to know if they've had any prenatal care, meaning have they seen a doctor about their pregnancy? Have they been taking any sort of vitamins or medications during their pregnancy? anything and everything you can find out about care before the actual labor is happening, because if they've had care versus if they haven't care can make a difference in whether or not you might expect there to be complications. If they've had prenatal care, sometimes they may already know that, for example, the baby is in an unnatural position and so they might have to have a C-section. That's a good thing to know. If they haven't had prenatal care, they won't know that. Or maybe there may be other things that go wrong, because there's a lot that can go wrong in a pregnancy. So it's good to ask. You also want to ask, when did labor pains start? Like I said, tying into that whole time thing overall. You just want to have a good picture of what their labor is feeling like at that moment and how long it's been going on. You want to ask if they're feeling the urge to push. Along the same time as this, you want to ask if they're feeling contractions. They're probably going to say yes, that it really hurts. You're going to want to know about those contractions, how long each contraction lasts, as well as the amount of time between each contraction. So the duration of the contraction, how many seconds, and as well as how much time from the start of one contraction to the start of the next contraction. When a woman is in the very first stages of labor, she might be feeling contractions every, 30 minutes or more or less. I mean, it can vary, but it'll be a longer amount of time. When the woman's about ready to give birth, her contractions are going to be lasting around 30 seconds to a minute, and they're going to be coming every 2 to 3 minutes. So if you've got a patient who is experiencing a 30-second contraction every 2 minutes, she's about to give birth. You can pretty much guarantee her body is preparing for this final push of getting the baby out. You want to examine her for crowning. Remember what I mentioned that what is? Crowning? Yeah, presentation. Usually the head, it can be something else. We'll talk about the other presentations farther down the slideshow. But you want to examine and see if you can see anything from the outside. If you can, really good sign that this baby's about to be born, then you need to start preparing for delivery. You want to take vital signs like you would with any patient. Again, being aware that a pregnant woman is likely to have generally higher blood pressure, increased heart rate, increased respiratory rate, things like that. Also be aware that somebody who's in pain is going to have a lot of higher heart rate, things like that. So the vital signs may not look like what you'd expect for an average woman of the same age who isn't pregnant and isn't in labor, but you need to go ahead and have them because you need to have that baseline just like with every patient. Along with asking if they feel the urge to push, you want to ask them if they feel the urge to move their bowels. Because of the way the baby, where the baby is and the pressure it's exerting on everything around it, sometimes when a woman is right about to give birth, they feel the need to defecate. And so that's just another sign. Maybe they don't have all the signs, but if they say that, you want to tell them, try to get them to not go to the restroom. Because there have been stories of babies who are born while a woman who's in labor is trying to go to the restroom. Be aware of that, ask that, and then try to prevent it if possible. Okay, you can sort of see this. I wish I'm going to turn the lights off real quick so you can see a little bit better. You can sort of see it. The baby's head's not going to look like a cute baby's head that is, in a movie or something. It's going to look all squinched up and weird colored and whatever. It's going to be, babies inside the uterus are formed inside of an amniotic sac, which is full of fluid that they kind of float in. It's got a lot of nutrients in, and it kind of helps keep them cushioned. The sac usually breaks. That's what we talk about with women whose water breaks. It doesn't always. So if that's still covering the baby, you're going to see kind of it's a whitish, grayish mucus, not mucus, but like an actual membrane layer. They're also going to be covered in mucus and blood and everything else. So this is more or less what it looks like. Okay, so with all those questions that you are asking your pregnant mother or soon-to-be mother, part of the reason you're asking those questions is to find out what kind of care the baby's going to need after the birth. So if they have not had any sort of prenatal care, if the baby is potentially being born premature, if there was some sort of trauma, if there is a chance or a knowledge of multiple births, meaning twins or triplets or something, those are potential findings that you may find that would indicate that the baby or babies might need resuscitation, might need CPR after they're born. Basically, these are just ways that birth can be a little bit more difficult than just your ideal, normal, complication-free birth. These are things that might cause complications. So you want to be aware of them and be aware what you might have to do for the child or the baby after it is born. Premature is meaning any child that is born before 37 weeks. So a pregnancy is 40 weeks long. We say 9 months, but in reality it's 40 weeks, which is slightly over 9 months. If a baby is born before 37 weeks, it's considered premature. And also if its birth weight is less than 5.5 pounds, it is considered premature. If a baby is born before, I think it is 28 weeks, although it says for sure in your book, or 26, it's potentially considered not viable, as in it's really going to have a hard time surviving. They can, it's just going to be a lot harder for them. But check that in your book, because I don't remember the exact number. Other things that you might find that would indicate the need for resuscitation of the baby after birth would be a history of any sort of problems with pregnancy. Placenta previa we're going to talk about, breech presentation we're going to talk about. Those are just 2 complications that can exist with any sort of birth. Also, you'd want to find out if they were drug users, alcohol drinkers during their pregnancy, and you'd want to know if potentially those overuse of those things can cause premature labor or other complications. So you'd want to find out for sure if any of those things are happening. And meconium staining. Anyone have a clue what this one is? Not too bad. Actually, meconium staining is when the baby basically has gone to the bathroom in its amniotic fluid. So traces of feces in the fluid. And why is that dangerous? Because it usually indicates that there was some sort of distress during birth. So something has gone wrong, potentially. We don't really know what, but it's a good indicator that there's a problem. Also, babies floating in this, that fluid is getting all over their body, in their lungs, everything. Do you really think it's a good idea for their feces to be doing that? Do you think it's very healthy for them? Not particularly. You want to be careful of this. It's something that can happen, but it's something that you want to guard against because the bacteria that are in their feces can potentially be causing issues for them as well. Meconium staining in amniotic fluid is going to look kind of either like a mustardy yellow or like light green or dark green, black, kind of. It can look a bunch of different things. But if you see that, if the fluid is anything other than pretty much clear, there's potentially meconium staining, meconium in the fluid. Okay, so normal childbirth. We're going to talk about what happens. Like I said, a cephalic delivery, that is when the head comes out first, right? Most of the time, the book has the percentage, but I don't remember it off the top of my head. Most of the time, the baby is born with the head posterior, or rather head facing posterior, so the face towards the woman's back. And then as they're born, you kind of rotate gently the head and shoulders to help ease the birth and also to be able to clear away their mouth and help them breathe. If delivery is imminent, okay, so imminent delivery we talked about contractions being how long? 30 seconds to a minute. And how far apart? 2 to 3 minutes. Okay, so if you've got imminent delivery, if you've got crowning, if you've got that urge to push or the feeling to need to defecate, all of those things kind of signal that maybe this is like really about to happen. It's best to not try to transport. If it's earlier than that, if they're feeling labor pains, go ahead and transfer them to the hospital. It's by far a better, safer, cleaner place to give birth. But if they're at this point where it's imminent, don't try to do both. Just go ahead and prepare for it so you can be in control and handle the situation as it's clearly happening right there. Proper protective equipment, okay? So do you think gloves are enough? No. We are going to go over this in a little bit, this obstetrical kit. This is the basic thing that you'd find on an ambulance. You can make do with a lot less, but this has, among other things, a ton of protective equipment in there. Sheets. You're going to want to use gloves. If you've got goggles, you're going to want to wear them. If you've got any sort of like gown, anything, okay? Because birth is messy. Blood and everything else is getting everywhere. So protect yourself, protect your environment, mostly protect yourself. That's the whole point of the personal protective equipment. But in general, you want to try to keep things as clean as possible for the baby's sake, the mother's sake, and definitely your sake as well. You're going to want to put the mother on a flat surface, so bed, floor, stretcher, something safe and flat, okay? You want to go ahead and make sure that their legs and their pelvis area are raised up so that you have good room to work in that area and properly deliver the baby. You want to go ahead and remove any clothing that is obstructing that area, you know, pants, underwear, that type of thing. You want to get your stuff positioned out as well as you can. That's why I was saying, if delivery is imminent, don't frantically try to rush to the hospital and find yourself down the road unprepared and not ready when the baby's about to come out. You want to go ahead and prepare the area, prepare yourself, get all your stuff out, and you're going to want at least one assistant to help you with this whole thing. Okay, so preparing the mother, they're just showing, these are, I'm going to open up the kit in a little bit. I guess it stopped the recording? No, it's still recording. Hold on.
Just did okay.
Okay, so I'm going to go over this kit later. We're going to talk about everything in it. But among the things that are in it, there's a lot of sheets, sterile gauze or plastic sheets that are meant to be used to protect the area as well. So you're going to have a couple under the woman, under that area. Remember, you're trying to protect the baby as well. So you don't want it to be like contacting the floor, just the bare floor or something, when it is born. You also want to properly protect the mother's legs, her stomach. This is to keep her warm, keep her comfortable, keep her a little bit covered. She's going to want some privacy, okay? As well as provide a sterile environment. Like I said, this whole kit is sterile. You're going to provide as sterile an environment as possible for this baby to be born in. Not a lot of germy, dirty things surrounding it. Okay. So this thing here, we're actually going to pause so we can talk about. Okay. So if you don't have one of those, if you are, when it says off duty, basically, if you are not really actually working on an ambulance at the time, if someone around you is being born or is having their baby, these are, I guess, sort of substitute supplies that you could use in a pinch. If you don't have anything better, this is better than nothing at all. That's why they call it off duty. Clean sheets and towels. For the same reason that you had these sterile ones, you want them to be as clean as possible. You're going to need them to, again, protect the area, protect the mother, keep the mother warm, keep the baby warm, all of those sorts of things. Heavy flat twine or new shoelaces. Any guesses on what this one's for? Umbilical cord. Yeah, y'all are totally right. Okay, the reason why it says heavy flat twine or shoelaces is because you don't want anything, you don't want to use like a sewing thread or something really thin, because if y'all remember from your physics, the amount of force that's going to be put in on that really, really thin cord is potentially enough to actually cut or potentially harm the cord in some way. And because there's blood that's moving through that cord, if what you tie around to supposedly just like hold that blood from moving anymore actually cuts through the cord, you've caused a really big problem, because now your baby's bleeding out and could bleed out and die very, very quickly. Okay, does that make sense? You'll want to use something that has no chance of, in the process of tying, has no chance of actually cutting through the umbilical cord. It's tough, but I mean, it can still break, it can still tear. You would want to have a towel, a plastic bag, something for the placenta, just like we had one in here. You want to have some sort of substitute if you didn't have a kit. As well as clean gloves, eye protection, anything like that, your personal protection equipment to keep yourself as protected as possible. And clean, I mean, you don't want to use something that isn't. Just, it's a baby being born. Their immune systems aren't as good. They can have a lot of problems. You don't want to do that. Okay, so delivering the baby. When this is actually happening, you're going to want to get your assistant that I mentioned earlier, somebody going to be at the head of the patient. The reason for that is to help kind of keep the mother calm, give them someone they can look at. They're also there in case something happens to the mother, or if the mother starts to throw up, which can happen. They're there to make sure that the mother doesn't choke on her own vomit or aspirate any of it. They help turn the mother's head to the side, you know, keep her calm, help her maintain her airway, that kind of thing. You're going to want to be down there, poised and ready. You don't want to ever stick your fingers, you don't want to touch unless absolutely necessary. You don't want to just casually touch that area. You also don't want to ever stick your fingers inside the vagina until it becomes absolutely necessary. In a typical normal birth, it's not going to be necessary, okay? So you just wait there for the baby. As the baby is being born, remember, in a normal birth, the head is coming out first. you're going to want to carefully guide the head out, supporting the neck, not pulling on the head, okay? I'm sure y'all know that, but still, no sort of tension pulling happening there because the neck is very fragile. Be aware, remember that babies have, what are these called, the soft spots in their head? Do y'all know the name for them? They're called fontanelles. I'm sure we'll go over it when we go over peds later. The soft spots in the head were the skull, which the skull is multiple bones, y'all know. The skull hasn't fully fused over and become hard like y'all's is. So those soft spots are places where the brain is not fully protected. You don't want to put any pressure on those if you can help it. Be aware of what those are. There's one like right up here, and there's one kind of on the back side. It's the anterior and posterior fontanelle. However, when you are delivering a baby, usually the head takes a while to come out, the shoulders can take a while to come out, and then everything else comes out really, really fast. And there can be something that they call an explosive delivery, which is just a very quick, kind of forceful delivery. Not necessarily a bad thing, but the problem is that if you're not in control of that situation, a lot can go wrong. One thing that can kind of help control it and maybe not make it so explosive is actually a little bit of very, very gentle, well-distributed pressure on the baby's head up here, just to make sure that it's coming out at the correct rate. You don't want to put any sort of pointed pressure or anything like that. This is, again, just sort of to help guide the baby's head out and make sure that it's not pushing its way out too forcefully. You don't ever want to try to push that baby's head or anything else, any other part of the baby, like back inside. That's not going to work. After the baby's head comes out, you're going to want to, again, like I mentioned, kind of turn it towards the side, head, neck, very gently. You're going to want to clean out the mouth as quickly as possible. If the sac, the amniotic sac that they were in, if that hasn't already ruptured before they're born, you want to go ahead and rupture it with like your forefinger, just poke a hole, it'll be fine. Be very careful. Be very careful. Some babies can be born with the umbilical cord wrapped around their neck. Okay, it's actually fairly common, but it is something you want to watch out for because the cord carries blood, oxygen, nutrients, everything, right? If it's around the baby's neck, are they properly getting any of that stuff? They can't breathe, it's wrapped, it's tight. It's like if you take a hose and you twist it where it's closed off, stuff's not getting through, and then obviously it's also choking the baby. Just a lot of stuff going wrong. You want to try to gently remove it from around the baby's neck if you can. So you'd take 2 fingers, slide it down underneath, and try to carefully just like push it over the chin. If you can get it over the chin, it'll slide right off the head. If it's wrapped more than once, it's potentially a cause to need to go ahead and clip the cord because it's not going to come off easily. If you can't get the cord off in one try, or maybe 2 tries, you want to go ahead and clip the cord because at that point, anything else is causing danger to the baby. If you allow it to remain on the neck, it's causing real danger. When I went through my EMT training, like I said, I had to see several births. One of the ones I had to see was a double wrap on the neck. And in the process of trying to slip it over the chin, the obstetrician actually managed to snap the cord in half. And the baby was bleeding very, very quickly because that's its blood flow, that's its blood supply. And it's like if you just chopped a big old artery in half. And the baby ended up being fine. He clamps it real quick with his fingers, and they were able to do everything okay. But it's something you want to be careful with. You don't want to casually treat this. It's fairly tough, but if it is wrapped around the neck, it's a cause for a lot of care to do it properly and to try to handle it the right way. We'll talk about clipping the cord later. Anyway, if there is no cord wrapped around the neck, or if you've already dealt with that successfully, the next thing you want to go ahead and do is open up the baby's airway as quickly as possible. Babies, infants, are nose breathers, okay? As we grow older, we learn how more to breathe with our mouth. But when they're born, the nose, or even when they're inside, the nose is the thing that is easiest to use first. What that means is that when you are trying to clear their airway, you want to clear the mouth first, okay? So think about this. If they've got mucus and stuff in their nose and their mouth, if you clear the nose first and they still have mucus in their mouth, all of a sudden now they can breathe. So they're going to breathe in through their nose, and the mucus that's in their mouth is going to get sucked down with it, okay? Versus if you clear the mouth first and then go on to the nose, then by the time they're actually able to breathe, everything is clear. There's no mucus, there's no other stuff in there, and they're going to have a much more clear airway. Does that make sense? Okay, so mouth first, then nose. You're going to want to wipe it from the outside, make sure there's not just a lot of excess fluid or anything around the mouth, and then you also want to take that bulb syringe and suction it. Just like with any other suctioning that we're doing, are we going in and starting suction on the way in? Okay. Are you going to go in and blow out and then suction? No. Okay, because if you're blowing out, like if you're pressing and then the air's going out of the syringe inside the baby's nose or mouth, whatever mucus was just there, congratulations, you've blown it farther down their airway. Sorry, I'm getting over something. So you want to go in with it pressed like this. Go in to their mouth about 1.5 inches and carefully release, controlling it the whole way. Bring it out, squirt it out into a towel of some sort, get rid of what was in the syringe. Do it a couple times, go into the nose, go in about a 1/2 inch or so on the nose, same way. Go in squeezed, release gently, and come out and like get rid of it again. Okay, after you've done that, the shoulders are going to be what's coming out next in a normal cephalic delivery. The upper shoulder usually will come out first. It may take a little bit longer. The shoulders are the biggest part of the body that's going to come out. So the upper shoulder will come out first, and the lower shoulder will usually follow pretty quickly. And then the rest of the body of the baby will usually follow pretty quickly on top of that. The whole baby's going to be really slippery. So you want to have good control over this part of the situation. You want to support the baby as it's coming out, supporting the limbs as they come out, the body as a whole. Remember, everything is very fragile. Neck, everything else. So you don't want to just kind of allow the neck to like move to one side or the other, or mess with the body at all. You want to be very careful at this point. And yeah, baby will come out. After the baby is delivered, after the baby is completely out of the mother, you want to lay them down at the level of the vagina, at or slightly below. You don't want to lay them on the mother's stomach or anything while the cord is still pulsing, the umbilical cord. Anyone have any ideas why that would be? Why would you not want to lift them higher while the cord is still pulsing as a pulse? Okay, you're dealing with blood flow. When you're dealing with blood flow, you're dealing with gravity because blood is a fluid. So you want to be careful, make it easy on the baby. Don't make it that much more difficult by somehow lifting them higher and making the blood have to work against gravity at the level or below. The cord will have a pulse. It'll be pulsating for a while, and then eventually that will go away. Once that's gone away, you can cut the cord. While the baby is, or immediately after the baby is born, you want to go ahead and try to get them dry and warm. If they've got a lot of mucus or things on them, all babies are born with kind of a white coating, I guess. I don't really know how to describe it. It's just sort of on their skin, whitish, grayish kind of. It's totally fine. They're born with it. It's called the vernix, and you don't want to remove it. It's actually somewhat protective for the baby, so leave it there. Don't try to take that off, but you do want to warm them and dry them vigorously to try to keep them warm. You want to mark the exact time of their birth, and you also want to label that somehow. Take a strip of adhesive tape, fold it over so there's no actual excuse me, there's no actual adhesive touching the baby's skin, and write on it the mother's name and the time of birth. Yeah, that's right. You know what to do if I die, or if I'm having an issue. Y'all know what respiratory distress looks like, and you know how to help, so be okay. Okay, so we talked a little bit of terminology at the beginning. When we say neonate, that's a term for a newly born baby or a newborn baby up to 1 month of age. Infant, remember, is up to 1 year, 12 months, but that neonate or newborn period is defined as the first month. When you were assessing a newborn, there is a scale. It's in your book. I don't know what page it is in y'all's because this is a slightly older edition, but it's a scale called the Apgar scale or the Apgar chart. Anyone have the book with them? Vanessa looks like she does. Yes. called the Apgar chart, and it should be. Okay, so in y'all's book, it's on page 854. It's in there though. When you read through it, you'll see it. But it's the way that we assess all newborn babies, and it's called Apgar because each thing stands for something. So the A stands for appearance. When we are talking appearance of the baby, well, first off, the Apgar scale, you can have anywhere from a 0 to a 10 as a score. So everything is worth either 0, 1, or 2 points. Appearance is basically talking about overall color. So if they're pink all over, they get 2 points. If they are blue all over, they get 0 points. If for 1 point, they're usually going to be like pink in the torso, main trunk areas, and blue in the extremities. Okay? Do you want me to write this on the board as we go along? Would that help? Okay. I'm going to pause this because it can't see what I do anyway. One of your main concerns with dealing with this baby right when they're born is keeping them warm. Heat retention, super high priority. You want to cover them up with a blanket. You're going to have a lot of things on your ambulance that might help, like regular blankets. Obviously, there was some stuff that came in your kit. There may be the kind of blankets that are like foil, kind of. They feel like Mylar balloons, but they're really effective at keeping body heat in. After the cord has stopped pulsating, the very best place to keep your baby, or to keep the baby warm, is where? Where would you think? What's the warmest thing in your ambulance? The mother. Okay? So you want to get that skin-to-skin contact, ideally. It's going to help keep the baby warm, because that mother is giving off good heat. It's going to help keep the baby warm, and obviously has a really big vested interest in keeping their baby healthy. So they're going to want to hold their child. It works really well both ways. Keeps the baby warm, helps, keep the mother calm and happy, and there's other good things that go along with it. We can kind of talk about if they're breastfeeding or things like that. You want to get the baby dry. You want to get rid of any wet blankets, any wet things around, because anything wet is going to keep them cold. Wrap them, keep them dry. Cover their head. You lose a huge amount of heat from your head, which most of us in here are girls and have long hair, so they probably don't even know what that feels like. But guys who have short haircuts can tell you how much it hurts in the wintertime. Yeah. You'd be shocked at how much hair, y'all know if you've got long hair how much heat can be kept in there. So babies don't have that advantage. Most of them are born with little to no hair. They need all the help they can get. You also want to try to keep the ambulance warm as well. Close the windows, cut off the air conditioner, whatever you have to do. It doesn't really matter if you're uncomfortable back there and you're kind of too warm, because the emphasis is on keeping the baby warm and safe and healthy. Okay, so cutting the umbilical cord. We looked at these clamps a second ago. Okay. Once these are on, once you have clamped and cut, you don't take these off, okay? The baby's body will naturally kind of remove the vascular connections. They'll just close them off, and they won't keep having arteries and veins running through the rest of the umbilical cord that's left attached to them. It'll come off naturally. That's what leaves you with the belly button. But these stay on. It's not your job to try to take them off or do anything else with them. When you attach them to the baby, you're going to put 2 of them on, obviously, because the blood flow is going both ways. So you want to stop it both directions, from the placenta side and from the baby side. One's going to go about 7 inches out from the baby. That 7 inches leaves a good amount of space for if they're in the hospital and they need to have IVs or anything like that. It's a really great, easy access to their bloodstream. So leaving that space just leaves space for something that might be necessary down the line. So 7 inches, and then 3 inches beyond that, you're going to put the other one, and then you're going to cut in the middle of that 3-inch space, right? Okay, so resuscitation-wise, remember we talked way back 20 slides ago about the resuscitative efforts, or the reasons why you might need to do resuscitation on a child Okay, we're going to stop here for a moment then so we can take a break. So we were talking about neonatal resuscitation. We talked about the reasons why you might need to do it or might need to expect to do it. You usually won't have to get to the point. They show it in this triangle because the top is obviously what it starts with. Drying them, warming them, simulation of like flicking the feet, rubbing the back, things like that. Like that kind of thing. You want to rub their body to try to get the blood flowing, get them annoyed enough so that they breathe. Because when they breathe and they cry, that's what you want. Because that shows that they're breathing well. If that doesn't work, you may have to go to oxygen. You're usually not going to do like what we think of with adults where there's a face mask on the little brand new newborn's mouth. Usually we do a technique called blow-by, which will be to take another sort of oxygen, like a non-rebreather or something like that, some sort of face mask, and you position it close to them, or even just oxygen like nasal cannula tubing. You position it close to their face, but not directly over it, because that's usually going to, A, it's not going to fit well, and B, they're really not going to like it. Get it close enough that some of the extra oxygen that's coming out of it is probably going into their lungs. It's just a little bit of extra help. If that's not enough, BVM, chest compressions, intubation and medications. I mean, these are things we do on adults. We just really don't want to have to do them on babies. They don't work as well. And if a baby actually is at the point where they need intubation, like it's a really serious deal. Usually, the top 2 levels are going to be enough for most of the time, most of the cases we see. We may have to do CPR on infants. The rules for CPR on brand new newborn babies is a little bit different. Typically on an adult or an older child, we would do CPR if there's no pulse, no breathing, right? Okay, well, if we've talked about babies, we've talked about infants and children, we've talked about how much greater their oxygen demand is, right? That's why if you've got 2 rescuers, you're doing 15 in 1. Y'all remember that? The ratio, you're doing 15 compressions to 1 breath, so you can be giving them more breaths. Because we've talked about how children are much more susceptible, not because of some sort of, they don't have heart attacks the way adults do. Usually their heart has an issue because their breathing is first compromised. Their heart will stop because, they breathed in too much water. They were underwater for too long or something. And so their heart stops because of that, which means that if you give them good breaths, usually the heart comes back a little bit easier. So for kids, for babies, for newborn babies, when we're doing CPR, we're not waiting until their heart or their respiratory rate get down to 0. If they get to that point, they're honestly too far gone. We can't help them because that oxygen is so freaking important when they're that young. So we do CPR if their heart rate gets below 60. Okay, now if you looked over there on the Apgar scale, we talked about below 100 and above 100. If their pulse is below 100, so if it's not above 100 automatically, we start doing rescue breaths, because what that's meaning is their heart's going a little bit too slow. We want to go ahead and give them extra oxygen, so hopefully that will help pick the heart up. If their pulse gets below 60, we start actually doing CPR, and we do it with the thumbs encircling method like what's shown on the slide, where you are around their chest and pressing with your thumbs on the breastbone. They're little babies, okay? Bone's really fragile, so you don't have to press super hard. This is going to be by far enough to get the right kind of compressions going. When you're doing rescue breaths, you're going to be going 40 to 60 per minute, okay? What's the regular adult rate for rescue breaths? Rescue breaths? Somebody, y'all know this. Regular adult breathing rate. 12 to 20. So rescue breaths are usually, you're aiming for somewhere in that range of 12 to 20, like we say 3 to 5 seconds per breath, okay? For babies, we're going from 40 to 60. We want to be at a much, much higher rate of breathing for babies. And compressions, if you're doing them, you're going at 120 beats per minute, not 100 beats per minute. So everything needs to be a little bit faster. Okay. Hopefully we'll never, ever have to do CPR on an infant. I hope. When you are dealing with a birth, after the baby is born, you now have 2 patients that you have to deal with, okay? You have a mother and you also have a baby. While the placenta is not delivered, and even for a while after it is, you really need to be careful that the mother is not bleeding too much. We talked about this with the gauze and stuff. The placenta is attached inside the uterus, okay? So when the placenta eventually detaches and delivers itself later on, it has basically torn itself away from the wall of the uterus, which means now there's a sore, there's like an opening, there's a wound inside the uterus. And it'll usually, the blood vessels will constrict fairly well. Breastfeeding helps the uterus get smaller, helps the bleeding stop. There's another technique called fundal massage, which is like massaging the top of the uterus, but it usually helps stop the bleeding as well. But bleeding is a real concern for just like mothers who have just delivered their baby. You don't want to just kind of focus on the baby and forget that the mom is there and she's lost a lot of blood and she's super tired out and all kinds of things are going on. You deliver the placenta, you try to control bleeding, don't put anything inside the vagina. So if you've got pads, you've got a lot of bleeding, pack it around the outside to try to soak up the blood, but you don't want to like put something inside. That's just meh. And keep them comfortable. When the placenta delivers itself, it will come out with the umbilical cord, the membranes, all this other stuff. You do want to preserve that. Sometimes the whole thing doesn't come out together, and if any part of it still remains inside the mother's uterus, generally speaking, the bleeding is not going to stop well. I have friends who have had children, and 2 weeks later they're still bleeding, like a heavy period kind of bleeding, and it turns out that there was a chunk of their placenta that didn't come out with everything else. And it was staying in there, and the uterus wasn't fully contracting, and so it was bleeding a lot. So you want to keep it all together so the doctor can assess and make sure that everything is fully out and the mother's in no danger anymore. Okay, we talked about this. The delivery of the placenta is very much like the delivery of the baby. Labor pains, it'll take a while. You don't want to wait super long for the placenta to deliver. It's not anything like having the baby come out. So it's not, as soon as the baby is born, you can probably start to transport. Once you've taken care of the baby and the mother, go ahead and transport. You don't have to wait around and like wonder, oh my gosh, when's the placenta going to come? That's not a big deal. You want to get them to the hospital. This is kind of showing what that fundal massage does. It's just, you can find the uterus in a woman, especially who's just had a baby, you can feel it a little bit easier because it's larger. But you find it, like I said, about a grapefruit size, maybe a little bit larger in a woman who's just had a baby. And you actually want to like kind of lightly press, just like you'd massage, your shoulder or something. Pressing on it, trying to kind of massage it around to eventually stop the bleeding and help it contract properly. It works. It works fairly well. You also, if you're trying to control a lot of bleeding, you want to go ahead and let them lower their legs some, still keep their feet up, in part for shock, because if they're still losing blood, that's your shock procedure. Keep them warm, cover them up, but they don't have to have like their hips and everything up in the air anymore. You can kind of put them in a more normal position. You definitely want to provide comfort to the mother, take those vital signs. Remember, they just had a baby, so it's like super happy and exciting for them, but also scary. Give them all of the comforts that you can, all of the encouragement and kind words, because this is something that, even though it's happy, it is very overwhelming, and they need all the support and comfort that they can get at this point. Try to make them comfortable. Try to remove a lot of the mess from around them if possible. It's just part of the whole comfort feeling, I guess. Okay, we're going to pause here. Most of the time, people who have ectopic pregnancies don't even know that they're having ectopic pregnancies because it's so early on. The clump of cells that would be a baby farther down the line is so very, very small because, if you look at it, they're blowing the ovary up to look bigger, or the fallopian tube, but it is really not big at all. There's no room for a baby to develop in there. Okay, another complication of pregnancy or related to pregnancy, eclampsia, which follows preeclampsia sometimes. Preeclampsia is basically a condition of hypertension, swelling, edema during pregnancy that a fair amount of women end up getting, and it just basically causes them to have to be very careful. You're going to see it in things like elevated blood pressure, excessive weight gain, a lot of swelling to like the extremities and the face. Eclampsia can develop because of preeclampsia, because of an ongoing condition like that, and it will usually lead to seizures. Altered mental status, it's something to be very concerned about if a pregnant woman has eclampsia. Something you need to get them to the hospital for right away. Okay, so In your book, it'll explain this. When it mentions the word abortion, it is usually, even though we talk about abortion, I guess from a political standpoint of being the voluntary personal choice type abortion, which we're not going to discuss in here. For the book's sake, for what we're talking about with the body, we're talking about something they call spontaneous abortion, which is also the same as a miscarriage. And that's when the body, for whatever reason, we don't really know the reason to this. It can be anything from trauma to substance abuse to just spontaneous, no real reason. It just happens. The baby is, the fetus, it's usually not fully developed. At some stage in its development, the body rejects it, gets rid of it, cramping. They're going to have those same labor pains, kind of the contraction-like feeling, a lot of bleeding, and the body just gets rid of it. They're going to have blood and tissue, and it's gone. I mean, it doesn't look like a baby. It's just the body breaks it down and sends it away for whatever reason. If this happens, if you are called out to a woman, and you're dealing with a woman who seems to be going through a miscarriage, who's having this kind of thing happen to her, she's going to need a lot of emotional support. This is not something that anybody wants to have happen. It's not really something that you can predict, but it is something that obviously if a person is excited about having a child, or even if they don't know yet that they're having a child, it can be really devastating for something like this to happen.
So that can happen without them even knowing they're pregnant in the first place?
It can. You don't, I mean, a miscarriage can happen early enough on in the pregnancy that you don't have to have already known you were pregnant. It's not something that, it will usually happen earlier on. It doesn't happen like with a full baby. It's like when this baby's not really fully developed yet. Okay, so trauma. Trauma can obviously still happen. Everything from, car accident to spousal abuse, to a lot of different things. The baby is pretty well protected against basic bumps and bruises. If a pregnant woman falls, remember that baby's got the big old belly around it, muscle, uterus, amniotic sac, fluid, all this stuff around it that is helping protect it from the basic little bumps and falls and things like that. So it's not like it's that crazy fragile. It's pretty well protected inside the woman's body. However, trauma will still affect it. Trauma can affect the baby. Trauma can affect the pregnant mother in ways that you wouldn't expect. So if there is some sort of pressing trauma on the abdomen or some sort of blunt trauma to the abdomen, not only could it injure the baby, but it could put just enough pressure on everything that's down there that it can actually cause the diaphragm to rupture. A lot of stuff can go wrong. So there's extra considerations to be had when you're dealing with a pregnant woman in a trauma situation. They can't breathe well. Remember, you've got some, like the intercostal muscles, that are going to help a little bit. But yeah, it's not going to be doing the good breathing that you were doing before. I mean, if that happens, you've got a lot of problems going on. It's not going to happen by itself. If you want to obviously ask if the pregnancy, or rather if the delivery seems to be premature or somehow unusual in any way, one of those questions that you ask along with all the questions that you're supposed to ask at the beginning is if there was any sort of trauma. If there was trauma, you want to find out if any of it actually was directly to the abdomen. It's one thing to have the kind of trauma where you, fall off your bike and hit your head on the ground. That's trauma, but it's not quite the same kind of trauma as having a steering wheel ram into your chest and abdomen area. You need to know what happened. That will help you understand maybe what you're looking for as far as what could have happened to the baby. Remember that the heartbeat is going to be faster, their blood pressure is already going to be higher just from being pregnant. So be aware of how that's going to look. They can lose a lot more blood before they start to obviously show signs of shock. 30 to 35% of their blood of what they have in their body can be lost. Remember, they already have more blood in their body anyway. So it can be a little hard to tell how much have they really bled out, how bad are they really off, because their body's really, really good at compensating with all that extra blood. It's not safe. I mean, it's not like they can just lose a lot of extra blood and be okay. But it can be very misleading, and you can sometimes not be sure what's, really how bad off they are. So you want to be very, very, very attuned to the signs of what might be shock. Okay, this slide is just offering another terrible, awful thing that could happen, which is, along with your diaphragm rupturing or other things, your uterus itself can rupture. I mean, just like any muscle, it can tear. This would be very bad. This would happen in trauma, or it could happen in trauma. It certainly is not a thing that's going to happen every time, but If you see a lot of bleeding, obviously there's going to be a lot of pain. If you know that your patient received some sort of blunt trauma to the abdomen, keep in mind that this could be a case. This could have happened to your patient. Okay, stillbirths, like we talked with miscarriages. Sometimes the baby will go to term or almost all the way to term, but die while they're still inside the uterus, inside the mother. It's called stillbirth, or the baby is stillborn. They're born dead. So sometimes the baby will have died sometime previous, and they'll be born with obvious signs of death on them. Everything from some amount of decomposition to, you know what the obvious signs of death are in terms of skin color and signs of decomposition, things like that. You may see that in a stillborn baby. It may not be as readily apparent. If they are very obviously dead, like have been dead for some amount of time, do not attempt resuscitative efforts. For one thing, it's not going to be good. For another thing, it's going to be that much more traumatic for the mother to see that happen if it's not going to help anything. And really, at that point, you can't do anything for the mother. You can't do anything for the baby. If they died a week ago and were still inside their mother, you have to help the mother because they're going through something that is ridiculously hard to deal with. Your main point at that point is to keep her as healthy and safe as you can. Transport to the hospital, transport the baby as well. Emotional support for her and her family is going to be incredibly important. If the baby, it has, say, a 0 on the Apgar scale, but doesn't have any of those obvious signs of death or hasn't obviously died quite a bit previously, go ahead and try to resuscitate if they just seem to be in some sort of arrest. We talked about that, but do your very best to save the baby. Be ready to provide life support. And again, transport as quickly as you can. Okay, so not only can the baby die inside the mother, but sometimes the mother can die for fill-in-the-blank reason. You still have a chance to save the baby, at least if it's close enough to the end of term that the baby would be viable on its own. I mean, you want to try. You want to do whatever you can. You don't want that family to lose the mother and the baby at once. So in this case, you would do whatever you needed to do CPR-wise, basically, to keep blood, oxygen pumping through that body, because that's the only way the baby's going to have any sort of support. Continue CPR until you're relieved, until they can do a C-section on the mother to try to get the baby out and help revive the baby further. But at that point, all you can do is try to keep something going to the baby so that they don't die as well. Really uplifting class today. Sorry, guys. Okay, we talked about some of these gynecological emergencies, not necessarily associated with pregnancy. Bleeding in general. Okay, bleeding is bad from anything. Whether there's pain or not, you want to assume that there's something definitely going wrong if it is not obviously part of the menstrual cycle. So treat it as a life threat, check for any sort of pain, monitor for shock, transport. Y'all know how to do that. Like with anybody who's bleeding. If there is trauma to the genitals, again, you know how to deal with trauma. It's really the same basic thing. Look for your mechanism, treat what you can on the outside. Be aware there may be internal injuries because of the fact that, generally speaking, genitals go inside and you can actually access that. So there may be trauma inside as well. Look for signs of shock, a lot of blood loss. What you would do with any sort of trauma to any soft tissue part of the body. Okay, if there is confirmed or suspected sexual assault, your first job is to treat any sort of immediate life threats to your patient. If, for example, you have a patient who says she was raped or shows signs of rape, your first job is to keep her alive, healthy, safe, ABCs, that kind of thing. You want to try to preserve as much evidence as you can. This is something that, I mean, the way our legal system deals with rape is certainly not ideal, but one thing they do try to emphasize is try not to go to the bathroom, try not to wash, change clothes, anything like that. Because all of those pieces are basically pieces of evidence. Anything that is on you, on your clothes, on your skin, they prefer for you not to. Obviously, a lot of rape victims don't necessarily follow that advice because they want to get it off of them in a way. And that's a thing that sometimes causes issues in terms of the chain of evidence from the legal standpoint. From your standpoint, you want to try to encourage them to follow those rules. But that's really not your primary concern. Your primary concern is the patient care. Examine genitals only if necessary, only if there's bleeding. This person's already felt violated. They don't need to go through anything else. And for sure, report. The police need to know, the authorities, hospital, everybody. You don't want to broadcast what has happened to this patient, but at the same time, you need to make sure that appropriate measures are taken. Any questions?
What if the baby's born with a disorder?
Say that again?
Like, what if it's born with a disorder?
Oh, okay. So if the baby's born with a disorder, like obvious that you can see? Oh, you mean like physical deformity or just anything?
Just like physically.
Okay, so if there's anything that seems not normal with the baby, again, your main goal is really, as soon as the baby is delivered, to get mom and baby safe, warm, dry, get your ABCs, and get her to the hospital. There's not going to be a ton that you can do out in the field to really fix or help any sort of stuff. You rate them, you do your assessment, life-saving measures, and transport, just like you would with any baby, really. Any other questions? No? Not good?
Yeah.
Okay.
That's a big chapter, huh? And